Thank you, sir. So we'll go with the next talk by Dr. JYOTI MATALIA. So she'll be telling about complex situations in pediatric cataract surgery. So as he said, the adult cataract, we are more interested in managing the nucleus. So how do you do the direct chop, dividend conquer, all these things. But in pediatric cataract, it's managing the anterior and the posterior capsules. So that's the difference between adult and pediatric surgeries. And now Dr. JYOTI will tell us more complex situations.
Yes. So before I move on, I just want to answer. So a lot of doctors have a problem doing a pediatric capsular excess in a child because it's very elastic. It tends to run off. So for their comfort, who somebody feels that they can do femtosecond laser would prefer to take the child because they are not comfortable. Otherwise, somebody who is routinely handling pediatric cataracts, knows it's the style and the trick of doing it, will not want to do a femtosecond laser. Okay, so now I will talk something about the complex pediatric cataract surgeries, tips for success. So one thing very important in any child, we have to have a good vitrectomy machine, a microrhexis forceps, and an endolite. Endolite is something I prefer to use basically for novice surgeons when they are not able to see the vitreous. Like with the endo illuminator helped obliquely on the limbus, you can easily see the PPC, which is very clear. You can also see the vitreous strands, which are not seen otherwise, because all the time you may not have an access to very, very good microscopes, very good options. So this can help you pick up, especially in those who are learning. So let me start by showing you some interesting cases. This is a patient who had a large capsular defect, and it's about how to manage a traumatic cataract following corneal tear.
First was a case of absorbed.
So as you can see,
following corneal
I
tear.
wanted the volume for this.
Releasing the
It's not
synechiae,
playing.
a thorough exploration of the capsular bag showed a wedge.
It's coming slow.
Yeah. I think, can you increase the volume for this?
First was a case of absorbed traumatic cataract following corneal tear. After releasing the synechiae, a thorough exploration of the capsular bag showed a wedge extending over 2 clock hours of absent anterior and posterior capsular support. So after aspirating the cortical matter, the remnant of the anterior and posterior capsules was retained as a support for the IOL, except for the central area to clear the visual axis. That is evident with the endo illuminator. Keeping in mind this capsular defect, a foldable 3-piece IOL was then injected in the sulcus with minimal manipulation to be placed over the leftover scaffold of both the capsules to allow the best stability for the IOL. This is the final position of the IOL with a vision of 6 by 6 parts.
So what you can see, I have not rotated or dialed the lens. You have to try to nudge it in because you cannot dial. This can slip out. There's an area of absent anterior and posterior capsular support. And secondly, remember that if you're putting it in the sulcus, it has to be a 3-piece lens. You cannot put a single piece in the sulcus.
Next case was a membranous absorbed cataract with a PC plaque and a high astigmatism of 5 diopter. A customized toric intraocular lens implantation was planned. Intraoperative 0 to 180 degrees horizontal marking was done. Due to the wrinkling of the anterior capsule, a careful capsular excess of adequate size was obtained using trypan glue and microrhexis forceps and scissors. The PC plaque was carefully removed and an anterior vitrectomy was done in the area of the pre-existing PC dehiscence as is seen here. The endo illuminator was used for the same. The intraocular lens was implanted in the bag and adjusted along the markings. At the final follow-up, the intraocular lens was nicely in place.
So what you can understand is a smart toric IOL. Smart toric IOLs are IOLs in which the toricity is already incorporated into the IOL. All you have to put it at 0 to 180. That helps, and that is the reason why, because of an existing dehiscence, we prefer to use a plate haptic so that it can go snugly between your anterior and the posterior capsules and stay in place. It will not rotate, so that we can incorporate for the toricity of -5 with this patient.
Next case was a
Okay, and this is now another case of a traumatic subluxated cataract. You can see here that there's a subluxation, and you also see a fibrinous exudation which is there and a partial subluxation. So now before you plan to do anything, I would not release this attachments which are there, the fibrin. You can see 120 degrees subluxation, the sphincter tear. So you'd stain it with trypan blue, and then you start doing your excess. Now in this case, you have to realize to decompress an intumescent cataract, otherwise it can give way. And then once the anterior capsule has become concave, you can go ahead and start a capsular excess. Remember to center it over your lens, not your pupil. Now the membrane is removed gradually and a vitrectomy is done in that area. So you see, after the vitrectomy, be careful that you don't eat up your iris pattern or also the edge of the lens. Then a bimanual irrigation aspiration is done and an CTR is inserted into the bag to inflate it properly. Now in the area of subluxation you can see a tunnel is made. We use the Gore-Tex sutures to fix the capsular bag with a CTS. You can see that it is passed through the CTS and this segment is then gradually pushed into the bag. You have to ensure that the eyelet comes over your bag so that it is pulled in the direction, and then you tie a Gore-Tex sutures. You have to do this suturing on the scleral wound which is at the maximum proximity of your subluxation. Bury it, and we have also used a fibrin glue to close it. Then you can just put in a single piece hydrophobic lens in the bag which is like a foldable. Try not to maneuver too much and you can see it is well placed and the subluxation of the lens is not seen. So this is another case who has come, an international patient who came to me, was operated for cataract about 2 years ago, but you can see there's no evidence of any IOL here. Patient was very sure, the mother, that we have put. So what is this? This is because after having done the cataract surgery, they had not sutured the wound, because of which there's a fibrous ingrowth. Now this ingrowth was already existing, so what do you do in a patient like this? Yes, we made 2 side ports and then tried to separate the synechiae which is there. When you're separating the synechiae, you can see the edge of the lens indicating it's come up. Now it is so adherent, we tried to lift up a flap of the membrane on the anterior capsule and did an anterior membranorexis in a particular direction to lift it up, and you can see it's completely adherent superiorly. So I did the other side port, put in the same forceps and tried to lift it completely up, which is remained adherent. I try to cut it, it's very, very hard, so I use a vitrector and to make an opening, see the edge of the IOL, you can see inferiorly. And then make 2 openings inferiorly to pass in the iris hook. So what you can understand is area that you want to expose is enough to pass the iris hook. So you don't need to put it superiorly, inferiorly, because you have to go behind the IOL and do a posterior membranectomy. Only the area. Now what is the idea here? We cannot be heroic and try to adjust the lens. We want to clear the visual axis, and that is our primary goal. And hence what we have done, see confirmation with the endolite, you can see the center part is cleared. We have put 2 iris hooks, and because we have not gone full thickness, you don't need to suture those iris hooks. But superiorly, we have also passed the other instruments, and hence we have put it at the same time we have to do suturing for them. So this was a patient who came pre-operatively. Post-operatively, we were able to achieve a clearing of visual axis and the child could start seeing. So in this case, trying to adjust is not going to help the child. We want the clarity in the visual axis, which we have given.
The next case was a mature traumatic cataract following blunt trauma. After releasing the posterior synechiae, a defect in the anterior capsule superonasally that extended to the equator was noted. After adequate staining of the anterior capsule, a good capsular excess was fashioned. Centering over the pupil without incorporating that defect. Thereby, the integrity of the capsular bag was maintained. Routine irrigation and aspiration of the cortical matter was performed carefully, and a foldable 3-piece intraocular lens was implanted away from the capsular tear. This technique allowed implantation in the bag.
So what you can notice is if you try to open up this particular wedge which was there between the two, you would never be able to put the lens in the bag. By maintaining this small strip that I left back, I could put it in the bag. So remember that when you have, if you are able to maintain anything where the bag integrity stays, you can put the lens in the bag, and that's very important in pediatric cases because there is a sudden elasticity in the bag, the whole thing will open up. So try to, even if it's a small strip, but it's important that if you can maintain the strip, you will be able to put a lens in the bag.
The next case.
So this is another case where there's a patient has undergone a penetrating keratoplasty, there's a graft intact and you are planning to go ahead with the cataract surgery. So prefer to do a scleral tunnel here because you do not want to enter anywhere close to your graft host junction. So we have done in the tunnel as you can see, and side ports again see that your entry does not go close to the graft host junction, and that is very, very important. Stain wherever required, put plenty of viscoelastic in the eye. Again after staining, because you can understand it's important to stain anytime the cornea can get a little hazy, and it's important to get that contrast. So as you can see, always center your capsular excess over the pupil so you can measure it of the absolute size. After doing it, we made the other side port and now the entry you can see is done behind the graft host junction. We don't want that to open up. This is a child, so we have to be careful. Again and again, you cannot put him to another PKP. A good hydrodissection is then done, and then the surgery remains routine. Remember not to have the bottle height low. We don't want too much turbulence in the eye, and then a lens is put in. Remember to suture all your side ports and the main port. This is very important because they can open up shear by the presence of the graft, and try to have less fluctuation in the anterior chamber and a less flow of fluid so that your endothelium doesn't get decompensated. Finally, about the management of posterior capsular anomalies. One is persistent fetal vasculature. So if you can see, this is a microcornea with a microchoria, small pupil. So we've used the iris hooks here. Now you can see the blood within the center part indicating the persistent fetal vasculature. A small rhexis is then fashioned. We need to have a small one. And remember, the superior side ports are allowing both instruments at the same time. So you don't need to make any extra side ports to allow the instruments to enter in. Here we are not trying to do a PPC, but using the vitrector directly to do a posterior capsulectomy to remove any special tug onto your, if there is a persistent hyaloid artery or anything. A quick short surgery to clean the visual axis by doing a good PPC and removing the thickening behind is done gradually. And thereafter, suturing is very, very mandatory whenever required. Please don't decide not to do it, because as you saw the previous case, there's a fibrous ingrowth which is there. Since the other side ports were small, I do not go fully to allow just iris hooks to go. You don't need to suture them. Finally, this is a case of a mature cataract with posterior lenticonus and PC dehiscence.
The last case is a mature intumescent cataract with posterior lenticonus and a pre-existing posterior capsular dehiscence, as seen here on pentacam. A small-sized capsular rhexis was fashioned to allow sulcus fixation of the IOL if need be. Hydrodissection was deferred in view of the pre-existing PC dehiscence to prevent sudden giveaway of the posterior capsule. An anterior chamber maintainer was used to prevent the fluctuations in the anterior chamber. Anterior vitrectomy was done in the area of the PC defect. Intraocular lens was then implanted in the sulcus, followed by an optic capture for a good centration.
So in this case, if there's already an existing one which is large, you can see there's also opacification of the vitreous phase. What we can do is first you implant the lens in the bag, as you can see, and thereafter do an anterior vitrectomy to clear the area. So you're ensuring that the lens is in the bag. So this is the other technique where the IOL is first put inside and then you do a vitrectomy. So I hope you've got sufficient tips about how you should be handling complex cases. There's a good part about pediatric cataract that you don't, no two cases are same. Each of them is a different case and you keep on learning as and when you keep on operating. Thank you very much.
Wonderful presentation.